Hello, everyone. Welcome to our webinar today, May 28th, 2025. I am Barbara Chizzy. I am the treasurer of the Community Health Nurses of Canada, and it's my pleasure today to be presenting and hosting this webinar today on the update on HPV-related cancers and disease prevention. And we have the privilege of having Dr. Nancy Durand return to speak with us once again. She also spoke with our group in 2023, and she has some important updates to share with us today. So first, I'm going to give a little bit of line acknowledgement, and then I'm going to give some background on CHNC. So I have the privilege of calling in today from my hometown, which is Winnipeg. And this is located on Treaty 1 territory, and it's also the national homeland of the Red River Métis and the ancestral lands of the Anishinaabe, the Innu, the Oji-Cree, the Dene, and the Dakota people. I encourage all of you who are attending today to please put into the chat where you are calling in from today, so we have a little bit of an idea where our participants are coming from. So a little bit about CHNC. We are leaders for a healthy Canada. We have membership of approximately 300 people across Canada. We always are welcoming new people to join CHNC and always looking for new members to get involved with the different committees that we have going. Some of them are related to education, research, leadership, but there's many more opportunities to get involved. So we please encourage all of you to join our organization. We'd be happy to have you. And we're just having gratitude for the people who are attending this webinar today. These are the priorities that we have for CHNC. So the first priority for our organization is to advance the health of people in Canada. Our second priority is to strengthen Community Health Nurses of Canada as the Centre for Excellence in Community Health Nursing. And the third priority is to build an effective organization. Some of the work that we've done over the last couple of years and going forward has been really important, and I just wanted to share a few updates with you. So we have updated the Canadian Home Health Nursing competencies. They're available on our website. If you go to chnc.ca, you can go to the website and find the competencies that are freely downloadable. They were updated in 2024, and they're currently the most up-to-date worldwide. As our president for CHNC, Karen Curry, has been part of the advisory committee for the public health core competencies, and these have been updated, and we will be looking in the future about updating the public health nursing competencies as well, but that won't be until later in 2026. What we're currently working on, though, is the standards of practice being updated for community health nursing. We have a scoping review that's been completed, and we are now coordinating an advisory group, and then we're going to start the eDelphi surveys in the fall of 2025. So some of you might be getting the emails asking us to join our eDelphi, and we would really like for you to participate and give us feedback about the standards. And then the final thing is that we have a conference coming up in 2026. We don't have the confirmation just yet, but we're looking at heading west, and we're looking at May for the conference, but please stay tuned. We'll be giving you more information shortly. So today's highlight is the webinar from Dr. Nancy Durand, and I'll give you a little bit of information about her bio. So she's an associate professor in the Department of Obstetrics and Gynecology at the University of Toronto. She received her medical degree from McGill, and she completed her residency at McGill as well. She's on staff at Sunnybrook Health Sciences Centre in Toronto, and she's in the Department of Obstetrics and Gynecology, and her specialization is in colposcopy. And she has a principal interest, area of interest in prevention of HPV-related diseases and cancer through HPV vaccination. She's internationally renowned as a speaker and a leader on HPV vaccination, and it's our privilege to have her here today. I'd also like to acknowledge that this webinar has very generously been supported by an unrestricted educational grant from Merck. At the end of the webinar, you will have a chance for asking questions to Dr. Durand. So please put your questions that you might have in the chat. You also can raise your hand at the end of the webinar to ask your questions. And May Tao, who is our secretary for CHNC, she will be moderating the question answer period at the end of the webinar. After the webinar, you will also be emailed an evaluation and a certificate. We would really like to have your feedback about the webinar so that we can build and improve our webinars in the future. And then you will also have a certificate that you can use for your own professional development needs. So without further ado, I am pleased to pass this over to Dr. Nancy Durand.
Thanks, Barb. I'm going to share my screen now. Just give me one sec. There. So thanks very much for joining us. And as you can see from really all across the country, we have people joining us today, which is really great when we're doing this type of teaching and webinar. And we're going to try to relate this topic to all of us, not just in one particular area. So as you can see, I'm going to talk about HPV-related cancers and prevention, and there's two kinds of prevention that we're actually going to talk about, primary prevention and secondary prevention. So I'm going to start with secondary prevention, explaining it. That's what we've been really doing for several decades, right? Where we're doing cervical screening and we're trying to detect people with precancerous cells to treat them and prevent them from going on to develop cervical cancer. So HPV is already getting into those people, but we're trying to prevent the cancers that it can cause. Whereas primary prevention is a little different. That's what we get through vaccination, where we're going to try to halt the introduction of the virus in the first place into getting into us. And we're going to see why that's equally as important as secondary prevention. So these are my disclosures. And as we mentioned, I do a lot of work with Merck here in Canada, but also globally, where we do educational speaking. And I also work with Moderna on emerging mRNA vaccines as well. What I'd like to do today is to start looking at the burden of HPV-related diseases, not just cervical cancer, but also all of the other diseases that HPV can cause, including head and neck cancers in males as well. I want to touch on the NACI recommendations that came out last summer, which relate to alternative dosing schedules for HPV vaccination, because that's certainly something that's a topic of great interest right now. And I'd like to discuss the transition that's underway in Canada from traditional PAP testing for cervical screening to primary HPV testing instead for cervical screening. It's not available in all provinces and territories yet, but I'm going to use the Ontario model, which just came about in March of this year, as an example. We take HPV and we divide it into high and to low risk types. There's not just one type of HPV, there's actually many different types. And the most common low risk types that we must be aware of are types 6 and 11, as you can see in blue. And these are going to cause about 90% of external genital warts and a lot of the low grade precancers that we see in the cervix. And then we have a whole bunch of high risk or oncogenic types, which are the ones that are associated with the invasive cancers that HPV can cause. But they'll also cause a lot of the high grade precancerous changes that we see in cervical screening. Now you'll see we have different colors there. Now the 2 blue are the most common low risk strains, and the 7 red are the most common high risk strains or oncogenic strains. And the blue 2 and the 7 red ones are the ones that are found in 9-valent vaccine that protect against those strains. Now, currently, HPV is known to cause 6 kinds of cancer, as you can see, for women, cervical cancer, as well as vulvar and vaginal cancer, for men, penile cancer, and for both men and women, anal cancer, and head and neck cancer, especially oropharyngeal cancer. And unfortunately, 4 out of the 6 of these cancers are increasing in Canada. We have to also remember HPV doesn't just cause invasive disease, it also causes benign disease, such as like anogenital or external genital warts and recurrent respiratory papillomatosis, where young children present with recurrent benign but recurrent papillomas on the vocal cords, which is devastating for those families. And if you look at the sheer number of cases, the benign cases far outnumber those that are malignant. So let's now think about our risk of HPV infection as we get older. So you might think that really HPV is only a problem for kids in their teenage years, in their 20s, and certainly that's when it is most common. But if we look at the prevalence of HPV infection, the chance that a person at any one snapshot in time has an HPV infection, we can see in women it gradually declines with age, but not to 0. So if we look out at age 50 in a woman, HPV prevalence still pretty high at 35%. And if we look on the right-hand side, it's quite different when we look at males. So for males, the prevalence of HPV infection is higher than for females, 65%. And as you can see, it doesn't decline with age, but remains constant regardless of age. So, what all this means is that sexually active men and women remain vulnerable to HPV infection and therefore diseases and cancers throughout their lifetime. Now, it's true that most HPV infections are going to clear or become undetectable all by themselves, and that's about 80% of people, but it's the remaining 20% of people who have persistent infection, especially with a high risk or oncogenic type. These are the people who are at risk for going on to develop diseases and cancers caused by HPV. Now, we talk a lot about cervix because that was the first cancer that was associated with HPV, but we can't forget about the other cancers. So, for example, anal cancer incidence and mortality is increasing around the world and here in Canada. And you might be surprised to see that the incidence in females is higher than the incidence in males. And we can think then about who are those women who are at high risk for developing anal cancer. It's going to be women that are previously treated for high-grade cervical dysplasia, high-grade precancerous cells, or for cervical cancer. So we treat the cervix and we remove those areas of abnormality, but we can't remove the HPV infection. And that means that these women will come in 10 to 20 years later with their invasive anal cancer. And we need to really remember this as primary care providers because those patients will no longer be being followed by gynae oncology. They're discharged back to primary care. So we need to have a high index of suspicion if people come in with symptoms of anal cancers. In males, the burden of disease is rising, both for benign disease, external genital warts, as well as malignant diseases like anal cancer, penile cancer, and oropharyngeal cancer. And if you think about it, the problem with male diseases is that there's no routinely available or recommended screening methods for males as there are for females for cervical disease. So we don't have the equivalent that we have for cervical screening for male diseases, especially for oropharyngeal cancer. So this means they're more at risk because by the time they're discovered, often their cancers are invasive already. So let's spend a few minutes on oropharyngeal cancer because this is important. Oropharyngeal cancer, the most common location is going to be in the tonsils. Most common location is the base of the tongue and then the soft palate. And it's like a ring around the back of the throat where these cancers occur. People may have symptoms, but often they don't have symptoms and they may present with a painless enlarged lymph node unilateral in the neck. The treatment is quite difficult for these patients. It may involve surgery, but most often involves intensive chemo and radiotherapy, which leaves them with really long-lasting effects from their treatments. The reason we talk a lot about oropharyngeal cancer is that it's increasing dramatically over the past few decades. So, for example, for males diagnosed with oropharyngeal cancer, it's doubled over the past 15 years in the United States, here in Canada, and in Europe, as well as in Australia. What's interesting is that opposite to anal cancer here, predominantly we see it in males. So the male to female ratio, it's about 4 to 5 times more common in males than it is in females. And typically, these are going to be young or middle-aged healthy males who present with oropharyngeal cancer caused by HPV. Now, here's a slide that we used to show that shows the declining incidence of cervical cancer in women, going down about 2% per year, plotted against the rising incidence, about 3% per year, of oropharyngeal cancer caused by HPV in males. And you can see that these curves have actually already crossed, so that we now could say we are shifting from something that was really thought of as a female-related cancer to at least gender-neutral cancer. And I say we used to show this because in Canada, this has shifted. While HPV cervical cancer had been declining in Canada since 1984, suddenly a report that appeared by the Canadian Cancer Society about a year and a half ago showed that cervical cancer is now rising by double that rate, about 4% per year, where it had previously been declining. This is now the highest rate of rise of all cancers in both men and women. And remember, this cancer is preventable. And if you think this rise is due to COVID, you're wrong because this rise was seen prior to 2020 when COVID happened. So it's not a COVID effect causing this rise in cervical cancer. So let's then look at our Canadian landscape with respect to HPV disease and vaccination. Well, unfortunately, we have suboptimal rates in our provincial school programs. While we have the ability to vaccinate all boys and girls across the provinces and territories in Canada, not every parent is consenting for their child in our school-based program. For adults, we have low adult HPV vaccination uptake that we need to change. And we also are now seeing a lack of coordinated national registries or linkage with provincial registries. So, in places where we do have a registry for vaccination, they don't talk to each other province to province. So, when you have an individual who moves from one jurisdiction to another, it may be very difficult for you to find out if they indeed were vaccinated years ago. And all of this is on the landscape of increasing HPV-related cancers for the cervix, especially in oropharyngeal, rather than decreasing disease rates. So this leads us to the idea of why might we consider adult HPV vaccination in addition to adolescent vaccination? Well, of course, the best practice is for us to vaccinate before the onset of sexual activity. Nobody's going to dispute that. The problem is the reality is that we have low coverage rates in our school-based programs in many regions. Also, many may not have had access to the national immunization program based on their age or based on gender, because boys were not included until relatively recently in the school-based programs. So then when we think about adult HPV vaccination, there's two ways that we can consider benefit. The first is going to be the benefit to the population as a whole, so as a public health goal, where we could fill in the gaps in lower national program vaccine coverage rates to help us accelerate us on the path to elimination, including those who didn't qualify. We need to think of this really as a multi-age cohort rationale where we vaccinate the adolescents, but we include also younger and older adults as well. But then we also want to think about that patient sitting in front of you, the degree of individual protection and the discussion that we should have to the individual. Because we know we do benefit adults. There's risk of new exposures, as we saw, and I'm going to show you there is efficacy when we vaccinate adults as well as adolescents, even people who've already had a history in the past or the present of HPV infection or disease. Isn't it really our job to provide accurate, up-to-date information and the opportunity for people to get vaccinated so that they can make the best informed decision for themselves? So let's review HPV vaccines over the years. Well, the first one that was developed was the quadrivalent vaccine in the middle. And this was licensed in Canada in 2006, so 19 years ago, and protected against the two most common low-risk strains in blue, 6 and 11, and the two most common and important high-risk strains, 16 and 18. Bivalent was second. This was licensed here in Canada in 2010. And now we have the 9-valent vaccine at the bottom. So the 9-valent vaccine includes the 4 types that were in quadrivalent and adds in the next 5 most common high-risk or oncogenic cancer-causing strains. So we often think as an adult, this is not going to work because we're older. Our immune system is aging. In fact, that's not true. When we look at adult clinical trials where we vaccinate those over the age of 26, we still see 90% reduction of HPV infections, external genital warts, as well as cervical precancers. And in males, similar, very high numbers, almost 90% reduction of external genital warts, and we have very high reduction of high-grade anal precancers. What about long-term follow-up? Because clinical trials typically run for about 3 to 4 years before you see this reduction of disease. But people in the clinical trials continue to be followed, and we now have up to 14 years of follow-up of women in these original clinical trials and males, which show no breakthrough cases of disease. And this is very important because we want to make sure that we don't have to do booster dosing. How about people with current or past exposure to HPV? They do, in fact, benefit from vaccination. It's not too late for them. We're not going to benefit anything that's currently existing. So those HPV infections that are there right now, resulting in external genital warts or abnormal cervical screening, this is not going to benefit what's currently there, but it can prevent new infections caused by types that the person's not yet been exposed to. Remember, there's 9 types in that vaccine. The chance that a person has had already exposure to all 9 types has been found to be 0 in the large clinical trials where this was tracked. Those clinical trials did also show that it can prevent subsequent disease from future reinfection with the same type that you've had in the past. So if you had, say, a type 16 in the past and you cleared that infection or it became undetectable, and then you went forward and had a new exposure to type 16, if you're not vaccinated, you still have risk of new infection. But if you were vaccinated, no people developed a new infection due to that same type. So we should not exclude this group of individuals because we think they can't benefit, that it's too late for them. In fact, they can benefit greatly. How about approvals here in Canada? Health Canada's approved HPV vaccines for males and females from age 9 to 45, and NACI went one step further and said that we should vaccinate anyone over the age of 9, and they chose no upper age limit. The indications are, as you can see, for prevention of cervical, vulvar, vaginal, anal, and oropharyngeal cancers and precancers, as well as anogenital warts. Last summer, NACI provided an update on alternative dosing schedules because this had been requested. And so our current dosing schedule has been for those who are 14 and younger, 2 doses separated by at least 6 months. And for those 15 and older, 3 doses at 0 months, 2 months, and 6 months. The NACI recommendations and statement last July now stated that the option is there to give 1 dose of HPV vaccine for age 9 to 20. And if you're 21 or older, the option is there to give 2 doses at 0 and at least 6 months. Remember, these are currently off-label recommendations in Canada by Health Canada and by the manufacturer. That's important if you're giving and counseling this to a patient, that we advise them that this is off-label use. For the immunocompromised, including anyone living with HIV, regardless of CD4 counts, NACI still recommends 3 doses, the full series of 9-valent vaccine be given over 6 months. For our provincial programs, people often wonder what has been happening in our school-based programs. They are all still 2 doses, except the exception of Quebec, who moved to 1 dose this past fall, and they had planned to move to 1 dose before this NACI update came down. So currently there's no changes in our school-based provincial and territorial HPV vaccination programs. I want to caution you on some of the limitations of the NACI recommendations. This NACI statement was based on 3 studies. Only one of these was a randomized controlled trial. This is called the Kenshi trial that was run in Kenya that lasted for 36 months or 3 years. And this was 2,200 females only, comparing 1 dose to 0 doses, which is a little different than what we're considering changing from 2 doses to 1 dose. The other 2 were observational studies, were not designed to look at this question, but they were just looking at people who happened to receive 1 dose instead of the full series. And again, females only, smaller numbers enrolled in these 2 observational studies. We have no male studies looking at alternative dosing, and this will be very important for us to understand the effect of alternative dosing on oral HPV infection and oral disease, because males are who is most affected with oropharyngeal cancer. The long-term duration of alternative dosing still remains unknown, as the longest study was only done for 3 years. We do have a large randomized controlled trial that will be reported during this next year called Escudo. This is more than 20,000 individuals, and this will be comparing 2 doses to 1 dose. So we all are greatly anticipating the results from this trial, that it should help us to answer this question better. Some countries around the world have moved to alternative dosing in their national immunization program, for example, Australia and the United Kingdom. They're a little different than Canada. They have high vaccine coverage rates in their school-based program, more than 90%. They have decreasing disease rates, decreasing external genital warts, as well as decreasing cervical cancers and precancers. And they have robust national registries for tracking not just vaccination, but who is having cervical screening and who's being diagnosed with disease and what treatments are they getting. So they can tie it all back. If there's a change required in the vaccination schedule, it will be easy to find those who had alternative dosing. Now, there still are countries like Sweden who have all of these things in place, excellent vaccination coverage rates, excellent decreasing disease rates, and very robust national registries. But Sweden has still chosen to stay with a two-dose program in their national program, which is school-based. So the cautions really for Canada, unlike those areas, is, as you know, our provincial vaccine coverage rates are not optimal. For example, where I live in Ontario, only 52% of kids in grade 7 were vaccinated last year. This means we have no herd protection for the unvaccinated. We've seen that cervical cancer rates are increasing, as are oropharyngeal cancer rates, not decreasing, and we have no integrated national registries for surveillance. Also, as I mentioned, alternative dosing is still off label, so this is something that we need to tell parents and adult patients if we're choosing to do alternative dosing. And one thing I would mention is if and when provinces or territories move to a one-dose schedule in school, the reported vaccine coverage rates will automatically, artificially increase because anybody with one dose only would now be considered completely vaccinated, even if no additional children are vaccinated. So now I want to spend some time on primary HPV testing for cervical screening. Now, this may be available in your region or it may not yet be. It depends where you live in Canada. The HPV test is a test that tests for 14 oncogenic or high-risk types, including type 16, type 18, and 12 other high-risk types, including type 45. The reason you'll see 45 mentioned is some tests will group it with type 18. What it can't do is test you for low-risk types of HPV like 6 and 11, which cause almost all external genital warts and many, many cases of ascus or low-grade cervical dysplasia in cervical screening. We have two types of tests that are available in Canada. The first is an HPV DNA test, which is made by Roche, and this is called COBAS. And for example, in Ontario, if you were running this test, it would have been previously done by Life Labs. And it's looking just for the presence of HPV DNA. The second test is an HPV mRNA test, a little bit different. Here, it's not just looking for presence of HPV, but the fact that HPV has been incorporated into the genome of the cells. So as you might think, the positive mRNA test is a little more dangerous than a positive DNA because it's already changing the cells. This is a test made by the company Hologic. In Ontario, this was done by Gamma Dynacare, and you might see on reports words like Aptima or Panther instead of COBAS. And this is the test that Ontario Health or Cancer Care Ontario has chosen for the provincial program that is rolled out now in Ontario for primary HPV testing. Other provinces like British Columbia and most countries globally have chosen the DNA test. And so that's important when we're trying to do research comparing, let's say, Prince Edward Island to Ontario to British Columbia. It's important because they're using different tests and their positivity rate will be different. It will be lower for an mRNA test than it will be for a DNA test. So what does it look like? How do we do it? The methods of testing that when we do a provider test, where the healthcare provider is performing the test, will be done the exact same way that we've been doing it all along. We put the speculum in. We have a little brush or broom that we use to collect the cells, the same as cytology, and it's the lab that's going to run the HPV test on the liquid specimen. You will have heard a lot recently about self-testing for HPV. British Columbia has included this as an option for any woman in British Columbia if she wishes to request a kit online and this will be mailed to her. Looks a little different, looks like a swab, and it's a vaginal test for HPV. Ontario, for example, is not yet offering self-testing to women in the province, but they are doing pilot programs, and it is available privately in many regions in Canada if the patient wishes to do self-testing. Why, though, have we moved from traditional Pap cytology, cells on a slide, to the primary HPV test as the first test to be done on women. The reason is accuracy. So, who you're really trying to detect with your test, whichever it is women at risk for high-grade cervical dysplasia, high-grade precancerous cells. Those are the women that we need to find and treat so they don't get cervical cancer. Well, the sensitivity for detecting that woman is very high with the HPV test, 96%, and as you can see, is not nearly as good with the Pap cytology, 50%. That means 50% of women with high-grade cervical disease will be missed by the Pap, and it will be called a false negative, where she really has disease. The negative for the HPV test is lower specificity. And that means when you test a whole bunch of people, you'll get lots of people who are positive for HPV, DNA, or mRNA, but who don't necessarily have disease. And that's a problem because what do you do with those people? If we send all those people to colposcopy, we will increase the load dramatically in colposcopy. So that lower specificity of the HPV test can be improved. And we do that by partial genotyping. So for example, the positive HPV test then can be typed to see are you positive for type 16 or type 18 or 45, which are more associated with invasive cancers than the other 11 high-risk types. These are going to be responsible for 70% of the invasive cancers. So on that positive liquid test, where we get a positive HPV test, we can do reflex cytology on the same sample, on the liquid sample, to see on the women that are HPV positive, what are their cells like. So it's really the reverse order of tests that we used to do, where the Pap was done first, and for certain people, the HPV test was then done. So I'm going to show you the example in Ontario of how do we manage patients. Even if it's not yet available in your province, it's good to be aware of what other provinces are doing to see the flow of patient results to understand when it may come in your area. So if the results for the HPV testing are negative, what does that mean? It means none of the 14 high-risk or oncogenic types were incorporated into their cells because in Ontario, you're doing an mRNA test. In Ontario, HPV could be present, like the DNA, but not incorporated into the host genome, and this would be reported as a negative. It does not mean the person doesn't have any HPV. It only means they're not showing high-risk oncogenic types incorporated into their cells. And it does not mean they can't transmit to a partner. So we can't tell patients, because the test is negative, you're great, you can't transmit to a partner, because I don't know that. Now, if the HPV test is positive, then the subtyping, you could be positive for type 16 and or type 18 and 45 is grouped with that one, or positive for 11 other high-risk types. That group is just given the group other high-risk types, and we won't get the specific type. They just are labeled as that group. And they have a lower risk, but not zero risk for malignant transformation. So they won't be handled the same as a person who's HPV negative. The intervals will change as we move to HPV testing because that test is more accurate. So now, if we're HPV negative, the next test is now done at 5 years instead of 3 years. The exception is if a patient's immunocompromised, we repeat it in 3 years. How do we define somebody who's immunocompromised? In Ontario, the list is here for Cancer Care Ontario. Anyone living with HIV, regardless of CD4 counts, anybody with a transplant, so a solid organ or a stem cell transplant, someone who's been on immunosuppressing agents for 3 or more years, anyone with lupus, regardless of treatment, and people with renal failure or who are on dialysis should be done every 3 instead of every 5 years. How about if you're positive? Well, if you're positive for type 16 or you're positive for type 18 or 45 or all of these patients will be referred in Ontario directly to colposcopy regardless of their cytology results. It will still be done on the specimen, but not for the primary care provider. That result is for me in colposcopy, and I will act on it when the patient arrives in colposcopy. Remember the person who's in the other group, other high-risk types positive. Once again, reflex cytology will be done, but here is where the primary care provider will need to act on it. The cytology after the HPV positive test could show normal cells or atypical ASCA cells or low-grade dysplasia. If it shows any of these low-grade or less results, the primary care provider repeats the test in 2 years, and if it's still positive, they go off to colposcopy regardless of type. If the reflex cytology shows anything worrisome, so atypical squamous cells cannot rule out high-grade dysplasia or high-grade dysplasia, atypical glandular cells, adenocarcinoma in situ, anything that sounds bad, these patients will also go off to colposcopy. So this is the one category where the primary care provider has to make a decision on management, whether they're going to keep the patient, repeat in 2 years, or whether they're going to refer automatically to colposcopy. Confusing, but it will get easier with time. But the launch of primary HPV testing as it unfolds across the country, and it will, is an opportunity. Automatically, we're going to have increased awareness of HPV and the diseases that it causes because we have to talk about the tests that we're doing and we have to talk about the results that we're giving. And we can easily link vaccination to these discussions because the first thing the patient asks, even if they're negative, is what can I do to ensure I remain this way? And these discussions can be had with the patient and also talking about the importance of vaccination for the patient's partner or partners. This can be done as we're booking an HPV screening test or cervical screening pap test. This can be done at the time of the test, and it can be done when we're discussing results. So we have a lot of more opportunities naturally available for us to discuss vaccination. We know there's a risk of new exposure even as we get older. We've seen that there is efficacy when we vaccinate even adults, and even that there's value to vaccinating previously exposed people as well. How do we have those discussions? Well, a very easy way to talk about it. This is a vaccine to protect you against cancer. These cancers are preventable, and we don't want to lose you to this disease. So we focus on this being an anti-cancer vaccine. How would I do that if I was giving test results back? Well, your test came back negative for high-risk types of HPV. This is great news, but did you know that we can vaccinate you against HPV even as an adult to reduce the chance of you developing an abnormal test or cancer in the future? Let's vaccinate you today. Or the next patient, your test came back positive for high-risk HPV, and we're going to need to do further testing, and we may need to refer you to a specialist. But we do know that vaccinating you against HPV, even after you've had a positive test, can help reduce the chance of future episodes of abnormal cells and diseases. Let's get you started. We can vaccinate you today. We shouldn't assume that a young adult in their 20s or even early 30s was necessarily vaccinated in our school-based program. Many males didn't qualify because they weren't yet being vaccinated in this school-based program, and many females may not have had their parents' consent to be vaccinated in this school-based program. And remember also when we're talking to adults about the value of HPV vaccination for themselves, these adults are also parents of children now or may in the future. And this will increase the likelihood of parents consenting for their children to be vaccinated in the school-based program. So it's really a dual benefit to both the adult program as well as the adolescent school-based program. But if we only talk about it during cervical screening visits, remember, we're going to lose the males in this whole discussion. All male diseases are rising. If certainly the incidence of oropharyngeal cancer caused by HPV in males is rapidly increasing in Canada. And we know that men who have sex with men are at higher risk for these diseases. So we must also look for opportunities to discuss this with male patients as well. You know that patients can sense when we're uneasy with a topic. Depends on how I present all of this information to you. If you can sense that when you ask me a question, I sort of say, well, I don't really know the answer to that. I'll have to think about that. I'm not sure. I'll get back to you about that. And you're not going to think there's value in vaccinating if I have that type of an attitude towards the topic material. So develop confidence with what you're talking about. If you don't know things, please ask for advice. It's very easy. The questions that you have, we've definitely been asked before, and we're very happy to help. And that I would say is the key is anticipate the questions the patients are going to ask you in advance so that you can have your answers prepared in advance. The more you do this, the better you'll get at answering those questions. We should be setting an example too. We should educate ourselves, and we as adults should be vaccinated ourselves. I'm vaccinated, my husband is, and my children, both male and female, are vaccinated as well. We really need to believe and show that we believe in the difference that vaccination can make. So while I can talk about this for ages, I love talking about this, we can't do that with patients. The simpler we keep our message, the higher the chance that we're going to get them vaccinated. They want to know, number one, does it work? Yes, it does. It's effective. Number two, is it safe? Yes, it is. And we forget about number three. This is the most important part. They're asking, do you recommend that I get vaccinated? Yes, I do. Let's get you started. We can vaccinate you today. I'm going to stop there, say thank you. I'm going to stop sharing my slides so I can come back and see you all.
Thank you so much, Dr. Durand. That was another incredible presentation that you've given us a lot of information to think about. I think that a lot of our the people who are joining today are working in primary care, public health, home health, perhaps all various areas across community health nursing and other organizations. So we're going to open it up now to questions. If you do have any questions, please pop them in the chat. May Tao is our secretary for CHNC, and she is going to be moderating the question and answer period. I'm going to get us started with the first question, Nancy. And I'm just curious as to why the different provinces are choosing the different testing methods between mRNA and DNA testing. Is it a matter of cost? Is it because that is going to be really a challenge going forward, isn't it? Like trying to.
Yeah, so you can probably tell that I wasn't super happy with the choice of test. Ontario is looking at it from a much more scientific standpoint because do we care who is just carrying HPV? No, from a scientific standpoint, we're worried about the woman who's at risk of developing cancer. And if just HPV is present, she's not necessarily at risk. The problem is really also Ontario was looking at the load that would be generated, like in British Columbia, there was a 40% increase in colposcopy when they moved to primary HPV testing, which is, as you can imagine, the resources that we currently have are already stretched. And so this would have been a problem. Cost-wise, the two tests were exactly the same penny for penny. So it's not a cost issue. Although the indirect costs of having so many people go to colposcopy would have been a cost issue, but the test itself, it's not a cost issue. So it's really more on the scientific basis that that decision was made in Ontario. But I do think research and tracking people is very important. And globally, people just aren't using that test as widely, although they agree it's probably a better test for what we're actually looking for. People often ask then, so we can test this in women. How come we can't do this in men? Why are we HPV testing men? It's only done in the clinical trial setting. So unfortunately, it's only in a study setting. And there's no approved HPV test for males because of accuracy of results is the reason. So we unfortunately are not able to test males the same way. Some males are tested in high risk populations where we do HPV testing for anal epithelium for HIV positive patients in HIV clinics. But once again, access is a problem. So it is difficult. As you know, there's not that many clinics that do this kind of work. And so if we started sending all males to HIV clinics for anal screening, we would have overload of our system.
So there's a couple questions, actually quite a few questions from the chat box. So number one, Nancy, it was awesome. The information. So can you comment on the fact that people over the age of 45 are not eligible?
So that's a Health Canada approval. And NACI has gone one step further and has no upper age limit for HPV vaccination. So those of us as clinicians actually do vaccinate people over the age of 45 because NACI has given that permissive statement allowing us to do so. Age 45 by Health Canada was an arbitrary age. Why was that number chosen? That is the age at which people were enrolled up until in the clinical trials. So they couldn't enroll everybody. They had to pick a number, and they picked age 45 to cut off enrollment in the original adult trials. That's why we come up with this age of 45. It's not to say it doesn't work when you're over the age of 45. So yeah, we definitely do vaccinate people, males and females over the age of 45.
Great. So the second question, it's actually keep coming. Second question is, does your risk continue to increase with age, even with no new partners, like no new
Great question.
possible, yes,
So
exposure?
you have a person, let's say myself. So I'm happily married with kids. Do I still have a risk of a new HPV infection showing up on cervical screening? Actually, I do. Couple of different reasons. I need to be very confident that I only have one partner. So my partner could have partners that I'm not aware of. So that's certainly one possibility for a new HPV exposure. But also, old HPV infections that I had in the past can reactivate. They can become, you'll see I use the word clear or become undetectable. Those are two different things. Clearing means you got rid of virus. Become undetectable means virus can also become latent or dormant below the level of detection. And we're now starting to look at that group of individuals with great interest. So we definitely do have a risk for new HPV tests being positive, even if we're not sexually active at all currently, but we have been in the past.
Thank you. So the third question is for those not covered under the provincial publicly funded immunization program, cost of the vaccine can be very prohibited. Are there support program in Ontario that can support clients who don't have private insurance coverage plan through work or other source related to the cost of vaccines?
So there is compassionate dosing available from the
Ah,
manufacturer. This is a third party company. So we, as the provider, the patient doesn't apply. We, as the provider, have to fill out forms for that. They then will communicate with the patient. The patient will have to give their income tax returns to show what their income level is. And it's quite restrictive when compassionate dosing would be considered. So it is available, but I wouldn't say it's something that's used widely. I would also caution you about believing that cost is the barrier for our patients. As providers, we often think this. We did a survey to look at this question of barriers in Canada a couple of years ago. We asked a number of physicians, both family doctors and specialists, and patients the same questions across country of Canada. We asked, what are the barriers to your patients getting vaccinated? And the patient, we said, what were the barriers to you getting vaccinated? More than 90% of physicians, family docs, and specialists said cost is number one barrier to my patients. How many of the patients said that? 18 to 20%. Much, much lower. So, what we perceive as the top barrier may well not be the barrier that we think it is. People do see value in cancer prevention. This is not something we're asking them to do every single year. After we finish this series, it is done and you don't have to repeat it. Now, I speak globally about this in many different countries and continents around the world. In every single country I've spoken in, I always ask, what is the cost for low rent housing for 1 month's rent in your
mm,
country? The cost of 3 doses of vaccination is always less than the cost of 1 month's rent. So, helping us to relate this to the patient of something that is equivalent in their life can be very helpful way of talking about cost. Cost varies where you get your vaccine. So, for example, pharmacy to pharmacy, it varies widely. And we all know, I think you know where I'm going here. The cheapest pharmacy to get your vaccine is always going to be Costco. It's about $35 per dose less if you go to Costco and you don't have to be a member. And if I want to make the price even cheaper for the patient, if we stock directly in our clinic, we can give the patient the wholesale price for vaccination. So there are many tricks to decreasing cost. I can actually spread doses out farther than 6 months if that's helpful, and often it may be to the patient. especially patients who may have partial coverage in a drug plan. We can spread it out with some
Mm.
uh, ingenuity over a course of 1 or 2 years instead of 6 months. So I think there's a lot of ways, and don't feel like I shouldn't talk about it. Those patients are going to be embarrassed. I know they can't afford it. You'd be surprised who comes forward and will afford this vaccine when you thought they couldn't.
Thank you, Nancy. Yeah, the idea is just to get the vaccine,
Yeah.
because it's effective and it's safe and it's recommended. So another question, if you are in a long-term monogamous relationship, can your partner have HIV laying dormant and infected you later on in the relationship? Or if you have HPV, is it transmittable upon first sexual encounter?
So both of those statements are true. The
Okay.
person who has dormant HPV could infect you later in your relationship. So as we age, our immune system's aging, and what we had been suppressing, we may no longer be suppressing. And suddenly my HPV becomes above the level of detection, and I could transmit that to a partner. The second part, could HPV be transmitted on a first sexual encounter? Yes, it's very effective at transmission, much more effective, in fact, than many other viruses. For example, HIV is
Mm.
less effective per sexual encounter at transmission than HPV is.
Okay, thank you. Next question. I'm just looking at the time. If a person was diagnosed with HPV, the next PAP was normal, and next PAP was well, does it come back monogamous positive?
Yeah, and so we can see different, and I know because we've done HPV testing in
Yeah,
colposcopy for many years, and there are lots of patients where I'll see HPV positive, positive, negative, positive, where it just dropped down below detection, or vice versa. I can suddenly see it positive and then have it go negative. So that is possible, yes.
great, great, great. Um, Another question, actually one of the last one. If someone has completed the full series for HIV-4, is it recommended to repeat the series for HIV, oh sorry, HPV no, 9?
So the question is, what would be the added benefit to revaccinating somebody with the 9-valent vaccine who got quadrivalent or bivalent vaccine? The answer is the 9-valent is going to cover 20% more cancer strains
Mm,
than the quadrivalent or bivalent. So I do discuss that with every patient who had previous first generation vaccine because it should be their choice if they'd like to consider the more updated vaccination. And we've done this with other vaccines. This is not something that's new.
mhm. Great. Oh, wow. The next one is, so can the vaccine prevent reinfection with a strain of HPV that has gone dormant in someone's body and research later on?
It's a great question. And this is a question that's being asked around the world. This is a topic of much research now. We don't yet have any evidence to say one way or the other whether it will or won't help prevent reactivation, but it will prevent reinfection from a new partner. If I had a type 16 and I developed a good antibody response and I suppressed that or cleared it, I could see a person who has a new HPV 16 and I could still get reinfected with that because my antibodies are not protective, except if I'm vaccinated. And we know that vaccination does have has 100% efficacy for reinfection with that same type. So there's reactivation within us. Not sure of that yet, but reinfection, yes, it does prevent reinfection with that same strain.
Right. Thank you so much.
Mhm.
This is all from the chat box, but if there is any more question, we still have a few minutes
Mhm.
for the audience to actually put it on the chat
And also for people to talk about
to
their
talk about. Yeah.
experiences across the country with HPV testing. I don't see anybody from PEI, unfortunately, because I'd be curious how that's going, and British Columbia as well. But those of you in Ontario, if you've done any cervical screening, let us know how you find that. It's difficult because we're having to switch to talking about the counseling and the the way of explaining you're HPV positive with a type that can go on to cause cancer.
Yeah, this is a question about the slide. Will we get the slide? I think we will get the slide.
Right.
Um,
The
oh
slides
no,
will
not the
not,
slide.
the
Uh-huh.
slides will not be sent out,
Right,
but the recording will be sent
the
out. So
recording. Right,
it'll
right,
take about a week or so for the recording to be transferred onto YouTube, and for that to be made and posted onto our CHNC website. It will also be sent to all people who registered for this webinar, because there was a lot more who were registered than who actually could currently attend the webinar.
Right.
And so you can share that webinar. That's freely accessible to everybody to watch that YouTube recording, but the slides are not going to be made available.
Great. So one more question. If I had a previous diagnosis, then have been negative for years, do you recommend the HPV vaccinations after age 45?
I do. So I do talk about that with patients, regardless of why I'm seeing them. So I don't just talk about it with people that I'm seeing, for colposcopy, but with any woman that we're seeing, male or female too, if I were seeing males in my practice. And the reason is we don't know our future. So people are having new partners much later in life than they previously did. Whether our relationship broke down or whether I became widowed, we need to consider the fact that the chance we're going to have a new relationship later in our life is extremely high. Just like with adolescence, we don't want to wait until you have new onset of sexual activity.
Mm,
So that's a reactive way of thinking about vaccination. We want to be proactive and protect people before these exposures occur. So, yes, I would talk about it regardless of your sexual activity. I would talk about it after the age of 45 because I think we have that unanswered question of
mhm.
if reactivation can be decreased by vaccination. That's definitely still an unanswered question as well.
Oh, thank you very much. Oh, that's a comment. Thank you very much. This was so informative. It's the same with me too. And the information was presented so clearly. So thank you so much, Nancy. And back to you, Barat. That's all from the chat box.
Thank you again, Nancy, so much for your time to speak with us today, and to Merck for sponsoring this webinar.
Yeah.
And just a reminder, we're going to be sending you out the evaluation. Please fill it in and give us your feedback about the webinar. We're welcome to have any ideas of what you might want to see for future webinars as well. And I wish everybody a wonderful day. Thank you.
Thanks, everyone.